Well, thank you all for attending this pancreatic session. I want to thank, first of all, to the Focus Ultrasound Foundation to allow us to be here, to still have this virtual meeting and to get together all these wonderful scientists that we have today in our session. And with no more delays, I'm going to give pass to the first presentation. The first presentation is coming from Michael Gray from the University of Oxford, planning and delivery of ultrasound-mediated hyperthermia for clinical targeted drug delivery. Okay, so I'm sorry. I thought that we were going to have the discussion now. Is there a question for Michael Gray? We don't have it from the audience, but I have a question for you. Well, Michael, do you have that in your case that you're using thermodox? And do you have considered thermogemcitabine as an option for these pancreatic cancer patients?
In the short term, no, only because the reason we're proceeding with the pancreatic trial now is because of the lessons we learned from using thermodox with liver. So methodology-wise, we're taking most of the lessons we learned from our recent liver and thermodox trial into the pancreatic cancer trial without changing much of else.
Okay. Can you also comment on the motion mitigation measures that you've used?
Absolutely. We are using something called high-frequency jet ventilation. And what this does is reduce internal organ motion from, in some cases, on the order of centimeters down to a few millimeters. We have a little bit of data so far on what to expect for specific pancreatic targets. And again, it seems to be on the order of maybe 2 to 3 millimeter RMS net motion. And it occurs also at a much faster rate. We use ventilation, so we're speeding up the tidal exchanges quite a bit, but the amplitude is smaller. And that's the main thing that we use.
Good. Somebody also is commenting that is this a periodic thing? I mean, it's a periodic motion, for instance, goes also along with the bubble motion and other motions of the inside abdominal organs?
I'm sorry, I'm not sure I followed the question.
Yes, if you can elaborate a little bit more on that. And this technique also goes with the motion of the abdominal organs, for instance, abdominal bowel or so?
I personally have only seen it in action in one pancreas patient. There's a separate trial going on right now in Oxford for HIFU ablation. So that's where I quoted the numbers from just a moment ago. But we also used it for the Tardox trial on liver. And we did image more or less the full abdomen during those trials so I could see the difference between internal organ motion with and without the high frequency jet vent.
Okay. In our case, we use that our anesthesiologists used to have a shallow breathing for the patients. Have you tried on that?
Yeah, I mean, we've looked at the comparison. There are usually opportunities in a procedure of our length, which is on the order of an hour or so, that based on what the anesthesiologist is seeing in the blood gases, they may say, all right, we need to pause for just a moment so that we can let some deeper breaths occur for a few seconds. And we do that so we can also see mid-treatment what the differences are. But we feel like right now, given all the other uncertainty that can go into this kind of treatment. It is ultrasound guided, not MR guided. By minimizing the organ motion just directly with jet vent is the safest thing for us to be doing.
Thank you, Michael. I don't know if some of the other speakers have any questions for Michael. Okay, so thank you for your talk. We're going now to the talk of Alicia Hendricks. Histotripsy is an effective pancreatic tumor ablation strategy that releases immunostimulatory molecules and promotes anti-tumor immunity. And question for you is about all your markers on tumor microenvironment, and which are very interesting. Do you think that, or have you tried, or have you measured inflammatory markers on this setup?
That's a good question. So what we've been looking for at this point is just looking more at like changes in the in vivo system, looking at changes in the immune cell populations. We have not done a lot of work yet looking at changes in the like cytokine profiles in the tumor or in the serum of the animals.
Okay, so and what's next in your studies, because you've completed a full set of things, and what are your plans for next study?
So my study that I presented was kind of like a two-part thing, looking at in vitro and in vivo. So for like the in vitro half, the future direction is, because we were comparing histotripsy to other ablation modalities, is seeing not only that we can release the immunostimulatory molecules, but how they actually can stimulate an immune response. So like challenging immune cells in vitro with supernate from the ablation samples. And then in vivo, we're going to start looking at more of, since this was a partial ablation with histotripsy, we want to start looking more towards what does a full ablation do to the tumor microenvironment versus the partial ablation that we achieved.
Excellent. Any one of the persons of the other speakers want to have any question to Alicia? Okay. So
hi, I did have a question, if I could.
Sure.
Could you talk a little bit about the PAN02 model that you used? I'm less familiar with that than with KPC, because how does it compare?
I don't know the model that you mentioned, but what I know about the Pancreatic model, it's murine-derived murine tumor, so we can grow it in any of the C57 wild-type mice. It's mildly metastatic, so if we do studies that go on for more than a month or two, we can start to find some metastases in the liver of the mice, but it doesn't have a large health burden on them, so we can have longer studies looking at the difference in survival.
Good, thank you. It was a good talk.
Thank you.
Alicia from the University of Virginia Tech. The next study that we did was that we heard was from Jordan Joyner from the low intensity focused ultrasound produces immune response in pancreatic tumors from the University of North Carolina. And one of my questions for that is what advantages do you have of this in front of thermal focused ultrasound?
Yeah, so one thing that makes pancreatic tumors different from other different types of tumors is that they have a really high interstitial fluid pressure, and they also have this physical barrier around the outside of the tumor. And so we really hypothesize that by using mechanical effects, we can overcome these barriers and hopefully allow, our future plans are to combine with immunotherapy. So we're really hoping that effects that we have from mechanical will help drug delivery and actually get immune cells to go inside of the tumor.
Okay, so it seems that microbubbles make a great effect on this case. I don't know if you have considered what belongs to the focused ultrasound and what belongs to the bubbles.
Yeah, so we haven't tried this study yet with or without microbubbles. So we're hoping that the stable cavitation effects we're not doing inertial cavitation with the microbubbles is really helping open up, I guess, the tumor nest and helping things extravasate outside of the blood vessels into the tumor.
How do you foresee to the continuation of these studies?
Sorry, can you repeat your question?
Yes, how do you foresee the continuation of this research?
Oh, yeah. So I do have some new data from another study that just came in right before the presentations were due. And so a couple of things that we wanted to look at were to see if the tumor size would have an effect on the immune cells that are coming in. And so after we treated, we waited until the tumors doubled in size compared to the first study. And we saw that some of the immune effects kind of went away. So it is definitely a time-dependent course and when you treat, which is important because a lot of times in pancreatic cancer, it is diagnosed late. So if you treat when the tumor has gotten larger, it is more difficult to get immune cells to come into the tumor nest. And we also, of course, want to treat orthotopic model. So what we treated was a subcutaneous model because we didn't have the image-guided therapy system at the time, but we have gotten that up and running in our lab. And so we're hoping to repeat these studies using orthotopic model and also combining with immunotherapy based on the results that we got.
Wonderful. Looks exciting. Any one of your co-speakers are have any questions for you?
Yeah, I just wanted to ask a technical question. How easy is it to do the IV infusion of the microbubbles in these mice?
So we use a tail vein catheter, and that is hooked up to a syringe pump. And so basically I have the concentration of microbubbles that I want to infuse into the tumor. And so I'll basically back calculate the flow rate in order to get like a certain concentration. Does that answer your question?
Yeah, you didn't have any problems putting the catheter in the tail vein?
No.
And sticking it there? Yeah,
it is pretty difficult to, I guess like technically, it definitely takes a lot of practice, but we used a Sequoia imaging to basically verify that we actually had microbubbles in the tumor before treating. So we were able to use the tail vein catheters for injection.
Okay, thank you.
Thank you.
Any other question?
I was wondering if you've considered doing repeated treatments or say weekly or bi-weekly treatments with this, because that's the sort of more standard of care when translated eventually.
Yeah, I'm glad you asked that. We have actually tried that. So we tried 2 treatments 2 days apart. And we found that the 2X treated group actually lost some of the statistical significance from the immune cells that came in. Now, we're not exactly sure why that's happening, but one hypothesis could be that after the first treatment, we did see immune cells infiltrating 2 days later. And so we could hypothesize that the second treatment had some sort of damage on the immune cells that came in from the first treatment. So something that we could try in the future is doing a treatment 1 day apart or even weekly. So we have kind of seen a theme across a lot of these immune studies that the timing is really important.
Good. Thank you. So we're going to the next speaker, Tatiana Kuklova, chronic effects of cavitation-aided gemcitabine delivery to pancreas cancer on tumor microenvironment in KPC mouse model from the University of Washington. We have a question for you, Dr. Kuklova. Although you saw suppression, the tumor growth was there. Do you think it was possible due to the insufficient quantity of immune cells reaching the target because of the fibrous environment?
That's a possibility. So the whole point of doing the therapy weekly is to disrupt that microenvironment, to disrupt the fibrous stroma. And I think our main problem really was that we weren't following those mice long enough, that our endpoints were too too soon. But we did see that the fibrous, on histology, that the fibrous environment is indeed disrupted in the places where we could reach, and the cells there were dying. And possibly the immune system just didn't have enough time to really come in and clean it up yet.
Any question from other speakers to you?
Anya, hello, how are you?
Hi.
I just wanted to ask, I may have missed it, but did you, was there a P-HIFU only group in this study?
No, it is, however, planned. I am glad you asked that, because so far we had the group of mice that didn't receive anything, mice that had pulse HIFU plus gemcitabine, and gemcitabine only. So it is definitely something we want to look at. And also I wanted to emphasize that these are the genetically engineered type of KPC mice, not the orthotopically injected ones. So we do have extra challenges of tumors occurring in various places and not necessarily acoustically accessible, as well as substantially more stroma than in orthotopic or subcutaneous ones.
May I just ask if there is a particular place or organ in the mouse that you see these extra tumors?
Great question. The problem is not yet. They will metastasize if given enough time. However, because of our restrictive endpoints that we had postulated beforehand, we just don't get to that tumor size that would induce those yet. But you're right, they go to liver usually, and to the lung is where we've seen them in some of the larger ones.
All right, thank you.
Thank you. We're running a little out of time, but we'll have questions for the last two speakers. Petros Mouratidis from the ICR from London, a demonstration of the use of microbubbles combined with low pressure HIFU to induce cavitation and anti-cancer effects in pancreatic tumors. I have a question for you. In your study, it's a very nice study, and I congratulate you for that. But I have seen that, when in the group of subjects treated with everything, I see that the effect added of the checkpoint inhibitors was very low, or a little disappointing. Do you have the same feeling?
Not necessarily, because it's a very difficult tumor to treat anyway. So it's not really an immunogenic tumor. Treating it with pretty much any drug out there will create no benefit. So even if I see a 10%, 20% result, is something that's heading in the right direction, if the difference is, let's say, 20%. And in addition, there is pretty much no optimization done on that. So there is always, I think if you get a 20% benefit in one model and then you try to optimize this by playing with the concentrations of the antibodies, with the parameters of the HIFU, with the microbubbles, let's say, for example, do infusion instead of bolus injection, you can increase on that benefit. So it's a starting point. So from that respect, I'm not necessarily disappointed, no. And sometimes I'm more worried when I see a very huge, big benefit rather than a small incremental one.
We have still time for one quick question from some of your colleagues. Anyone has a question for you? No?
So you mentioned histologically, you see most of the damage you see is the hematoma, but do you see disruption of the tissue outside, next door, sort of, to the blood vessels when you do this?
It's the blood vessels in there are not that great, are not that big. So you do see damage in the tumor, but you always have to compare with the necrotic, with the control tissue that sometimes or most of the time will have some necrotic parts in it. So it's very difficult to be 100% sure whether the damage you see with these low p-HIFU treatments with the microbubbles is actually a real one or just a necrotic one that will have been there anyway. If you increase the pressure, increase the treatments, the exposures you do in a single tumors, then you can start seeing this effect of destruction more evidently and be 100% sure that you're actually completely destroying the tumor and the blood vessels. Yeah. So in these ones, I think it's very difficult to distinguish it from the necrotic tumor, the necrotic parts of the tumor that you will see anyway, because they are relatively large tumors, 300 millimeter cube, 400 millimeter cube, etc., etc.
Well, thank you all for for being here in this excellent discussion. I have to close and finish this, and please keep on this virtual meeting for the next sessions. Thank you all.